Yeah, so today's session is a bit on demand because people going for FRC Part 2 exam, they have requested for certain specific films. Uh, they thought that they are having difficulty in differentiating between infectious mononucleosis, CLL, and ALL. So the trick for the exam is that you need to focus on the history and then on the presentation and then on the cell count, so white cell count. A patient of infection mononucleosis will always be a young patient from 15 to 24. A patient of ALL will be a young as well, but his counts will be 200, white cell count will be 200 or 300. Infectious mononucleosis counts cannot be 200 or 300 or 800. Their counts will be like 11 or 12 like that. CLL patients on presentation are usually asymptomatic. The films are usually from the GP film or it comes with hemolytic anemia, and the counts are usually above 50 as well. There is uh, quite a lot of difference between CLL blood cell, white cells and the ALL cells, which you will see now. Yes, they do have some cells which have some scalloping on the red cells, but it does not mean that this is infectious mononucleosis. Infectious mononucleosis cells have basophilic cytoplasm. They are few in number, not abundant like CLL. So we will see them now. So I would like to have a volunteer for the first case, please. Right, who wants to go ahead first?
Yeah, I can go for it.
Oh, okay, right. So this is a 24-year-old boy
Yeah.
who presented to GP because of fevers and some swelling in the neck.
Okay.
The full blood count shows white cell of 16,
Yeah.
but the BMS biomedical scientist called you that there are some abnormal cells which he think like acute leukemia or leukemia like cells, and he wants you to review the blood film urgently. His hemoglobin is normal and his platelet count is 150. So this is the power 10. So I will go through power 10 to give you a general overview.
Yeah. So, a low power, I can see there are increase in the white cell count, moderate increase, um, likely mature, but I can't appreciate uh, any
Okay.
platelet
So
power.
so you will go to 50 then?
250, yeah. Okay. So, all right. So starting with the white blood cell, uh, there is, I would say, like atypical lymphocyte, but to describe it is large mononuclear cell um, with abundant cytoplasm and vacuole.
Okay.
Mm,
Yeah.
okay, all right. So again, there is another likely atypical lymphocyte with large large cell compared to the red cell size, abundant cytoplasm with I think the nucleus. It seems like it's not like the condensed or compacted chromatin. It's more diffuse, but it's not. Yeah, I
Oh,
can't appreciate nucleoli. There are a couple of mature neutrophils.
okay. So how would you report this blood film for the exam purpose?
Okay. Um, I didn't comment on the red cells and the platelet. The red cells, it seems relatively um, normal. Yeah, there are few echinocyte, and it seems like normal platelet. So in terms of the report, I would say there is slightly increased uh, white cell count, mainly um, lymphocytosis with atypical lymphocyte. No obvious blast could be seen. Um, Preserved hemoglobin and platelet counts. Um, mm, to exclude um, infection, mainly infectious mononucleosis.
Okay. So you have answered two section of the report. One is missing.
Mm, um,
You have commented on the film, and what do you think is this film consistent with?
yeah, um, the film is consistent with reactive lymphocytosis, likely
Mm-hmm.
reactive lymphocytosis, I would say.
Okay.
Um, in light of the history and age of the patient, um, infectious mononucleosis needs to be excluded, so we need further tests.
Yes. So while reporting the blood film,
Mm,
always comment on the cell line which has the problem. This
yes,
blood film, uh, the problem was in the white cell count. So
yes,
comment on the white cells. This blood film shows lymphocytosis.
yeah,
The white cells are atypical, mature, with basophilic cytoplasm and prominent scalloping around the neighboring red blood cells. The red blood cells are normal
mm,
with few uh, um, echinocytes, you can say, or poikilocytes. They are very few. Or if you
very,
say that the red blood cells are normal, that is fine as well.
yeah,
The platelet counts are normal as well. There are no blasts. The most likely uh, diagnosis or the blood film is most probably consistent with a reactive picture. To exclude infectious mononucleosis, um, the patient would need some further tests, um, like viral serology or
yeah,
monospot test. So then, comments on the blood cells, your probable um, diagnosis and suggestion of further tests. This will
Mm.
complete your report for 6 marks in the FRC path exam.
All right.
Okay. Then
Yeah.
the next question in the exam would be for 2 marks. What are the uh, set of investigations that you would likely to do? So this is the repetition of your a section of blood report. You would
Yes.
do viral studies, hepatitis B, C, and HIV,
Yeah.
monospot test as well. And the third one you can write as the EBV PCR.
Yeah.
And then the last question would be, what is the most likely diagnosis from this scenario? So you can say the most likely diagnosis from this scenario is infectious mononucleosis or reactive lymphocytosis because the patient has fever and he has lymphadenopathy and he is young, he has reactive lymphocytes, there are no blasts, the count is only 12,
Yes.
and they have prominent scalloping. So most likely it is consistent with infectious mononucleosis or reactive lymphocytosis. So this would complete your question, and for sure you will get 9 out of 10 marks in the exam.
Okay. Yeah.
All right.
Yeah. Thank you.
Infectious mononucleosis or reactive lymphocytes, they it's very common in the short case of morphology. So try to collect the blood films, make your own boxes during practice if you are currently practicing to keep them for your part 2 exam.
Sure. Thank you.
Now we have a second case, again a 24-year-old boy. I need a second volunteer, please. Anyone volunteering for the second case?
Yes, I can try.
Okay. Right. Again, this is a 24-year-old boy, and you have been called by the biomedical scientist regarding the blood film and the white cell count. The patient itself presented to ED in a confused state. The CT scan in the emergency department shows intracranial hemorrhage. The biomedical scientist noticed that the platelet count is very low. It is 94. The white cell count is very high. It is 960. And the hemoglobin is 102. He thinks that this film is consistent with chronic myeloid leukemia. So this is the general overview. This is the power 10.
Okay. So I can see there is a leukocytosis on the peripheral phlegm.
Going to 50.
Yes. Okay.
Okay, you can start commenting or reporting the blood film. The first question in the exam would be report the blood film. For any short case and long case, they would say report the blood film, report the define, or report the aspirate.
Okay. So WBC are increased in number, and they are these are abnormal. I think promyelocytes or slash blast, and these are atypical cells. These are small to medium in size with high NC ratio.
I don't know what do you mean by promyelocyte or blast.
Okay, these are atypical cells with these are immature cells with high NC ratio, and there is scanty amount of cytoplasm, which is agranular, and the nucleus is somewhat open and cleaved. Few cells are also showing cleaved nucleus, cleaving in nucleus, and these are small and medium size. And RBCs, these are most likely normostatic normochromic, and platelet are reduced on the peripheral smear.
Okay. So you have commented on the um, cells. The film
Yes,
is most likely consisted with
consistent with leukocytosis, most likely acute leukemia.
acute leukemia. Okay. What next?
So further investigations are required to confirm the diagnosis, like bone marrow aspiration biopsy, FISH or cytogenetic, or EML RARA, and flow cytometry to confirm the acute leukemia.
Do you think this is emergency?
Yes, this is emergency, and refer the patient to under the care of hematology, and start the uh, coagulation profile investigation for the coagulation profile investigation. And if there is possibility of the ETRA, so start the ETRA, and supportive measures as there is already intracranial bleed. So resuscitate for the
Why
bleeding.
why you think this is APML?
Because like there is cleaving in the nucleus, and these are not in a good shape, and the patient is young and came with bleeding, and WBC count is high. Like this these type of the cells, few cells are giving the appearance of dumbbell and butterfly shaped appearance. So I'm not confirmed, but I'm just giving this suspicious.
So you would say this blood film shows leukocytosis. The white cell count, the white cells have high NC ratio. Some of them
Hmm.
has prominent nucleoli with
Hmm.
agranular cytoplasm. The
Hmm.
platelet count is low, no platelet clump seen.
Yes.
The red cells are normochromic normocytic.
Hmm.
The film is most likely consisted with acute leukemia.
Hmm.
Given the patient presentation and bleeding, This is a hematological emergency which need to be assessed by hematology urgently, and urgent flow need to be submitted for diagnosis.
Mm.
And urgent hematology intervention is required, which is reducing the white cell count.
Mm.
This is not APML. The cells are not bilobed, they are not granular, they are not large in size, they are just a bit large than the red cell. And APML would not come to you with 960
Okay.
white cell count. So you cannot say whether this is acute myeloid leukemia or acute lymphoblastic leukemia on morphology. You can only say probably acute leukemia.
Okay.
Uh, the, the, the lineage differentiation is always on the flow. The flow will tell you whether this is myeloid or this is BALL or this is TALL, whatever the flow cytometry is. You cannot do bone marrow biopsy in this patient. He has a bleed. He has been, he is confused and unconscious with low GCS. So it's very difficult to do invasive procedure in a patient like this.
Okay.
Right. Why the patient has intracranial hemorrhage?
Because of leukostasis.
What the leukostasis will do? What the high white cell count will do to do the bleeding?
Leukostasis produce the blood flow obstructions, or maybe increase the permeability of vessels. So it produce intracranial bleed where the resistance is high.
Okay. So when the white cell count is high, the red cell count is high, or the platelet count is high, they consume the von Willebrand factor, and they can produce acquired von Willebrand disease, which can make the patient prone to bleeding. So you may have seen acquired von Willebrand disorder with polycythemia, with essential thrombocytosis, or in a very high white cell count. They consume the von Willebrand factor and multimer that lead to intracranial hemorrhage.
Okay.
But in this case,
Right.
this patient also has a thrombocytopenia, which could also cause intracranial hemorrhage.
Yes, it is 94. I think I mentioned the platelet count is 94. So
90.
yeah, so not that much to cause uh, bleed.
But on smear, they don't seem to be 94.
Yes.
These platelets are few platelets are visible.
So this is a 50 X field. So you can see multiple here.
So, Dr. Ahmed, this patient would need, you said he also needs a hematological intervention. As you said, we cannot uh, define the lineage on the basis of morphology. So, as these cells did look like ALL, so do we say to start the pre-phase steroid? So, what intervention do we advise if we are not sure about the lineage of these atypical cells?
Mhm. What do you think we should do in this patient to reduce the white cell count?
Usually, in if we are suspecting ALL, so you start the pre-phase steroid and also cytarabine. But usually, if it's AML, then we can also start do the cytoreduction with hydroxyurea. But I'm not sure what is the protocol in UK and what they do.
So he came with a bleed, life-threatening bleed, and the white cell count is 960. So we leukapheresis him for consecutive 2 days and reduce his white cell count from 960 to 100.
Another question is that if you are not confirmed that this is ALL or AML or APML, because we not sure about the still abnormal promyelocytes. So leukapheresis is contraindicated in that case.
Yeah, but this is not APML. APML has typical bilobed nature. I think I need to bring out the APML in next session as well. And they don't have cytoplasm like this, small cells like this, or high white count like this.
But hypogranular variant can be seen like this. I have seen so many cases of
Yes.
APML. They're having the
Hypogranular,
very, yes, they
hypogranular
have.
usually come with pancytopenia, and hypergranular usually come with hyperleukocytosis, but it would be 30, 50, 60, not not 900, not 700, not 500.
Okay.
Sorry, you have mentioned the things in reverse order. Hypergranular present with pancytopenia with low TLC, and hypogranular variant it present with high TLC.
And vice versa.
Hmm. And one more thing, is there any cutoff for which you will advise the leukapheresis?
It depends on the patient clinical presentation because the chemotherapy will reduce the white cell count slowly. We need a quick reduction in the white cell count in this patient because he has intracranial hemorrhage, and that would continue to increase if you do not intervene quickly. That's why we did leukapheresis in him and reduce his white cell count to below 100 in 2 days.
So if there is some delay in arranging the leukapheresis, can we start the hydroxyurea even it's ALL?
Yes, you can start, but ideally, um, all the ICUs here they are equipped with apheresis machines, so we do not face such things here in reality. Okay, so the last question in this patient would be the risk stratification. What are the high risk? What are the poor risk factors, and what are the standard risk factors?
Uh, if it is supposed to be ALL, then age, gender, counts, cytogenetic.
No, not like this. I'm asking you, what are the high risk factors in this particular patient?
But high TLC count,
Mm-hmm.
and he's a boy, I think. Yes, he's a boy.
Okay.
And intracranial bleed is also a risk factor.
And intracranial involvement. Yeah. So
Yes.
always read the question, what is asked from you. Sometimes the questions are general, and sometimes they ask you about this particular person. If I have asked you a general question, it would be a different answer. I have asked you about this patient, so it would be a different answer.
Okay.
Right.
Dr. Amir, can we discuss viva of this case, ALL?
Viva, in this case,
Mhm.
yes. The other Viva question, uh, they would ask you what is the flow cytometry markers for a BALL and TALL. Then, then the next question would be what are the general high risk factors in a patient with acute lymphoblastic leukemia. and what are the standard risk factors in a patient with uh, ALL. Then, what is the immediate management of this particular patient, which we have discussed? Then, what further investigation would you like to do, which would include coagulation profile, close fibrinogen. Um, if the patient is settled now, then bone marrow biopsy for karyotyping, cytogenetics, and flow cytometry and molecular mutation. Then uh, the next question would be about the management. So you have to explain the diagnosis to the patient based on the bone marrow biopsy result and discussion regarding the treatment. He is a young boy, so in the scenario did not mention to you anything regarding his comorbidities. So you have to um, discuss the different treatment options or trial if available in your hospital, patient wishes, his religious belief because he would need blood transfusion, uh, information leaflet to the patient, CNS contacts to the patient, and discussion in MDT as well.
For
If
this
you,
patient,
yeah,
sorry, go on.
so if you have a trial open in your hospital, which is open in all UK hospital, which is altogether trial, it's a new trial in young patient for less than 25. You can enroll the patient in altogether trial if the patient agrees. If not, then you can give him any you call um, treatment, which is the you call 14. Usually, if the patient is uh, Philadelphia chromosome positive, but we enroll this patient in altogether trial. Then the examiner would ask you about um, some side effects of the chemotherapy drugs because altogether or the UCAL protocols they include methotrexate, asparaginase, vincristine. So any common side effects with these medications or any antidote of these medications and for the side effect. Then MRD monitoring of the ALL by flow or by mutation. And then what if the patient relapse, the ALL patient relapse, what you would do then? Uh, you have option of blina or inotuzumab. Now we have started CAR T therapy for ALL as well, but I don't think they would go into a detail of indication of CAR T for ALL patient with you, but they would discuss the third line of therapy if the patient does not respond to. Sorry, before that, they would ask you regarding the blinatumomab or inotuzumab uh, worse effect or side effects. So inotuzumab is anti-CD22 and it causes VOD, while blinatumomab um, it is a
19.
it's a continuous infusion therapy for 4 weeks, and its side effects is the neurotoxicity and sometimes affect the CD19 population as well, so making the CAR T a bit difficult. And then, uh, if the patient relapse again or refractory to blinatumomab or enotumumab, what are the options you have? Either allografting or CAR T, depending upon which one is important. So the vivo question will start from a case scenario, like this patient uh, presented to ED with intracranial hemorrhage and BMS was concerned regarding how high white cell count and leukemia. Then the examiner would ask you, what do you suspect? he may give you a paper with description of blood film report, so you can have an idea that this is going towards ALL. Then when you say that you would do further investigation like flow cytometry, he would give you flow cytometry. This is the flow cytometry to make your diagnosis. Then uh, he would ask you regarding prognostic factors, which include multiple mutations and translocations. He would give you a paper which would say Philadelphia positive or negative, uh, uh, Notch 1 positive or negative, MLL or PBX or 922. All of this information will be given. So he will provide you piece of information as you go forward. He would not keep everything in front of you at once. So you would take the case with him like this, and then investigations, then um, a discussion with the patient regarding management, choice of therapy from the patient. They would not ask you about the detail of any protocol, like what drugs are involved in altogether, how you will give, what is the dose. No, nothing would be asked like that because you have only 7 minutes for one question in the Viva, and they want to ask um, as much questions from you in the Viva as possible. Like they want to take the question from the beginning to the management to the end, so they would be quick as well. So
Let's
these
suppose
would be. Mhm.
there is no protocol is running in your trust, and will you offer this patient UKLL 14 or 12?
So our hospitals, all of the hospitals in UK, they have the altogether trial running on for the young people less than 25. If not, then the patient is transferred to a tertiary hospital where they can give a trial to the patient. The previous trials are a bit old. You altogether trial is a new one, and all the young patients, if they are fit, they to enter, they are enrolled in them.
So do we have to go through this trial
No,
of
no, no. I
UKLL?
I asked you that if you open the altogether trial, it is 496 pages, a
Mm.
protocol, so no one can read it. Yeah. So just remember who can enter into the uh, altogether trial, who can enter into your call 14 trial, who can enter into your call 19 trial, who can enter into your call 60 trial, and that's fine.
So we need to know the exclusion and inclusion criteria.
Yes, a bit like uh, altogether trial in UK. I think it is from 0 to 25 or 0 to 29 years age in UK. Double check the 25 or 29 age, the upper limit. The ALL should be a new diagnosis. It should not be a refractory or relapse one. Patient should be able to consent, and patient should be a resident of UK. And if it in a case of female, she should not be pregnant. And exclusion criteria, as I mentioned, it should not be a relapse case. It should not be a Philadelphia chromosome positive, and um, the age criteria. The patient should not be above 29. In other European countries, the age limit is high, but in UK, I think it is either 25 or 29.
What does this mean? That patient should be able to consent. If you are including 0 to 25, so this doesn't make any sense. How come a 3 year or a 5 year old or child
So
can
three
give a
year
consent? Hmm?
so 3 year old patient, the parents would be consenting for them.
But
So the
what does this
patient
mean? That patient should be able to consent.
Yes, this is for the adult people. After after 16, you can consent in the UK. Before that, the parents can consent if uh, the patient is unconscious. And usually, it is the parent who are involved in consenting procedure
So this protocol is applicable to pediatric population as well.
as well. Yeah. Right. Okay. So a third case. Who wants to go ahead with the third one?
I can try.
Yeah. So this is a 58-year-old male who who went to GP for routine blood tests, and uh, the GP noticed that the white cell count is high, 76, and he asked for the blood film of this patient. Then the biomedical scientist or the lab scientist called that he is seeing some abnormal cells in the blood film which looks like leukemia. So this is the power 10.
On power 10, it seems to be a high TLC count.
Okay. And power 50. Yes, you can start commenting.
So the blood film shows leukocytosis with predominant population of mature looking cells, which are variable in size and have irregular nuclear contour. They have high NC ratio and their nuclear chromatin is condensed with no prominent nucleoli. Um, and some and the neutrophil count is also preserved, seems to be preserved. There are also smart cells on the smear, and the RBC morphology seems to be normocytic, normochromic, and the platelet count seems to be low normal. The blood findings are most likely consistent with the lymphoproliferative disorder, and would like to confirm the findings by flow cytometry on peripheral blood.
Okay. So the flow cytometry result, the patient has CD5 positive 23 positive, 43 positive, 200 positive, and it gives you a diagnosis of chronic lymphocytic leukemia. Um, do you want to treat this patient?
As he's asymptomatic, you would like to carry out some further investigation, like the test of hemolysis to rule out any underlying hemolytic process going on. And also, you will uh, do the LDH, the protein electrophoresis, with followed by immunofixation. And then you will also ask for bone marrow biopsy and will do the cytogenetics, some molecular genetics like TP53 mutation or IGHV mutational analysis. And if the patient is asymptomatic, you just observe the patient 6 monthly for the first year. And
Okay, so you mentioned that you would do bone marrow biopsy. He is TP53 mutated and IGHV gene unmutated. Would you treat this patient?
if he's asymptomatic and his TLC count or his lymphocyte doubling um, count is static, then I will not treat him. We'll just observe him 6 monthly.
Why do you want to do bone marrow biopsy then?
Um, because when I want to treat, so I would have the baseline bone marrow and to have the tumor uh, burden assessment, whether it's a diffuse involvement or there is any nodular involvement.
If it is a bone marrow involvement, he would have cytopenias. This patient does not have cytopenia.
On first instant, I will not go for bone marrow. You want to say this?
His count is slightly high. He is asymptomatic. He needs monitoring only till he develop any constitutional symptoms or any uh, increase in the counts or hemolytic anemia, splenomegaly, any lymph node that is compressing the um, nerves or blood vessel, then you would think about treatment. He may continue with this level for 10 years like this. His blood counts maybe 20 or 30 or 50 for 10 years.
When we do bone marrow biopsy in CLL,
When you have cytopenias,
if we know this cytopenia is due to a hemolytic process, still we go for bone marrow.
yes, if you are planning, if he has any indication of treatment of CLL, then you decide to do the bone marrow biopsy to find out the TP53 mutation, to find about the Notch1 status, SFB31, BIRC3 status, RGHV mutation status.
I want to do marrow if I want to start the therapy.
Yes, then you would do the bone marrow biopsy to find out the TP53 status and other molecular mutations status to find out whether this is a bad prognosis or good prognosis, standard prognosis.
For that, we want the bone marrow sample.
How would you do the molecular mutations?
But some mutations can be found out in peripheral blood by fish, like 17p deletion or its loss. It can be
Done by blood, but the other mutations,
some mutations of them.
Notch1, SFB31, BIRC3,
Mhm. For that, you need a bone.
deletion, deletion 13q status, deletion 11q trisomy 12, all these. And it would also tell you about the involvement, the degree of involvement of bone marrow as well, if you are planning treatment.
Dr. Amar, if a patient develop cytopenia, not due to the hemolytic anemia or not due to the autoimmune purpose, but due to the infiltration, then is it indication for the bone marrow biopsy and
Yes,
treatment?
because cytopenias is itself an indication of treatment of CLL. The patient would be staged as Binet C.
Hmm.
And if you read the indications of CLL treatment, one of the indication is the cytopenias.
Yes.
Then, then you would need the prognostic stage of the patient for which you need multiple tests like TP53 loss or mutation, multiple molecular mutations to find out whether he is of a bad prognosis or standard prognosis, and then you would decide regarding the treatment drug. Although almost all of them are same in terms of treatment, like for TP53 mutated and without mutated, but the difference is of the ibrutinib. You can give ibrutinib only if there is TP53 mutation or deletion.
Even if he's asymptomatic, still we go for further investigations as a routine workup.
No, no, we don't do any investigation if the patient is asymptomatic and he's not requiring any treatment. We just monitor them, as you mentioned, 6 monthly. Yes, for 6 monthly, we monitor him to keep an eye on his lymphocyte count.
No, if this patient comes to you and you find out that he has CLL, but although he's asymptomatic, but you won't do the rest of the workup, the test for hemolysis, the LDH, the immune protein electrophoresis, or the immunofixation. You don't want viral serology. You don't want to
If
go for them or and the other organ involvement.
if the hemoglobin is normal, why I would do hemolytic screen for the patient?
And what about the staging? Will you do the CT scan to find out where there is any abdominal or mediastinal lymph node involvement?
If he
Because
has
it
lymphadenopathy, he would have constitutional symptoms as well. He would have night sweats, weight loss as well with that.
if let's suppose he's stage two, you won't do the staging at his diagnosis.
A staging CT scan, you mean?
Hmm. No, no.
Oh,
Like we stage the patient is on whether it's there is only lymphocytosis or there is only lymphadenopathy. Sometimes the lymphadenopathy is occult. You cannot find it on the physical examinations to find out whether what is the stage of the patient. Although
yes,
he is asymptomatic, you want to these investigations.
staging CT scan would be done. Yes, I agree with that. But if there is if there is any cytopenia, if the hemoglobin is less than 100, platelet is less than 100, then he is already a stage 3. Sorry, Binet stage C. So any cytopenias in the CLL patient needs treatment. It means his bone marrow has been involved.
It means the stage A doesn't need any CT scan for at the diagnosis. If the asymptomatic stage A patient, you doesn't need any CT scan for the diagnosis. If you have uncertainty about the diagnosis, then you can only do the lymph node biopsy, as I remember from the CSH guideline.
So Binet stage A is if there are 3 lymph nodes are involved, 3 or less than 3 lymph nodes. Binet stage B is if there are more than 3 lymph nodes are involved. Binet stage C if there is any cytopenia. So lymphadenopathy can be palpable or it can be not palpable. Lymph nodes may be in the mediastinum somewhere. So the staging CT scan will tell you where is the lymphadenopathy, and how many lymph nodes are there. So
So
if the
that's
staging,
so
yeah,
that's
if
my
the
question. Okay, do we do this staging CT?
yes, staging CT scan is done for every malignancy, but not other investigation like you mentioned hemolytic screen. No, if the patient is not cytopenic, why I would go for a hemolytic screen? If
Okay.
the patient is not cytopenic, why I would do bone marrow biopsy for this? You just need monitoring 6 monthly.
Okay, got it. Thank you.
Okay, if cytopenias develop, it means his bone marrow is now involved. He would need the bone marrow biopsies and all other investigations because you are planning a treatment for him, right?
Yeah, thank you.
Excuse me, Amir, I have a question, please.
Yeah.
Yeah, just back to the morphology of this film. I know that with the history and with the counts, like it looks like CLL, but the cells for me like it was mature lymphocyte, but there was a bit of pleomorphic appearance. So like it's not that always like should not be um, monomorphic appearance for the CLL.
No, in CLL there is no monomorphic appearance.
Okay.
Uh, if you see the blood film of 5 CLL patients, there would be some difference in the cells appearance.
Yeah.
As you go toward the thicker side, the cells uh, would become more smaller and smaller without any cytoplasm. As
Yeah.
you go toward the thinner side, towards the tip, uh,
Mm.
the blood cell, the white cell will become bigger in size with more cytoplasm, but clear cytoplasm.
All right. So it would
So,
be expected to have
sorry?
pleomorphic. It would be
Yes,
expected. Mm.
yes, because in CLL, you can expect some degree of pro-lymphocytes as well.
Yeah.
So if they are less, they are usually less than 15%. They are bigger than the usual CLL cells, but they have a
Yes.
prominent nucleoli as well.
Yeah. Okay. All right. Thank you.
And let me check if I have another film of CLL. So this is also a CLL blood film, and you can see it is a bit different than the previous one. Here, the cells become open. As you go to the thinner side, the cell size a bit increased,
Yeah.
but the nucleus is very mature, dark in color. As you go towards thicker side, they start to get shrink in size more and
Mm.
more. And here they appear just like the same size of the red cell almost with the-
Yeah. And yeah, thank you. So like because sometimes like it could be also, with the mantle cell lymphoma, because this is the mantle is characterized by the characteristics it would be like pleomorphic. So
yes. So mantle cell lymphoma has 5 different subtypes according to the new guidelines. Small cell variant, marginal zone variant, pleomorphic, blastic variant. There is one more as well. That's why we say in reporting the blood film, most likely or probably consisted with
Mm.
CLL, mantle cell, or follicular lymphoma. We cannot make a diagnosis on the blood film. That's why you always suggest in the third part of the report that you need to do flow cytometry to confirm the diagnosis. And when
Mm.
once you do the flow cytometry, um, you will have a clear picture whether this is CLL, this is mantle cell, or this is something else.
Sure.
We have a blood film of a patient which was um, just like an ATLL, a clear flowery shape cells of the patient, and everyone from junior to senior to consultant even mentioned that
Mm.
this looks like ATLL. But when the flow results come back, it was CLL.
Mm.
Yeah, I
Yeah.
had posted the picture of that case in our LinkedIn, in our uh, Facebook group as well, with a comment that do not uh, uh, make a diagnosis on the blood film. You
Mm.
need investigations like flow cytometry, biopsy, cytogenetics to confirm a diagnosis.
Sure. Yeah.
Okay.
Yeah. Thank you very much.
Good.
Sorry, Dr. Amir, in this CLL case, in further investigation, we only advise flow cytometry, or we will still say that we need bone marrow biopsy or cytogenetics?
Flow cytometry,
Only flow cytometry.
bone marrow biopsy, and cytogenetics you would do only if there is cytopenias, or you think there is bone marrow involvement, or you think you need to treat this patient.
So it's more safe to report always a bone marrow finding consistent with LPD, and we should not comment on the immunophenotyping unless and until and unless we have the flow report.
Yes.
Okay.
So in the exam, if the flow is given to you, then you have to say the flow is consistent with this diagnosis. If flow is not given to you, then you would say most likely this film is consistent with this diagnosis. I need further investigations like flow cytometry or bone marrow biopsy if it is a leukemia to confirm the diagnosis.
Okay.
On the blood film, you cannot make a diagnosis. Even if you have a APML blood film, you confirm it later with FISH or PCR or bone marrow biopsy. Right. So the last case, who wants to go ahead? Anyone?
I can try again.
Okay. This is the last case for today. Uh, this is an 18-year-old female who is immigrant to the UK, and she was referred by GP to us because she's feeling very tired and lethargic. She was on a transfusion program back in the home country, but she does not have any files with him or any cards with her to tell you what was the diagnosis. Her blood film is in front of you. Her hemoglobin was 52, so she has been transfused as well. MCV is 71. Platelet count is 142. White cell count is 4. This is the blood film. What do you suspect this patient has?
From the history, it seems to be she has some hemoglobinopathy. That's why she is on regular transfusion. And her indices are of microcytic hypochromic.
Okay. So report the blood film, just like you would do for the exam.
Okay, the RBC morphology shows dimorphic blood picture along with an isopokilo. There are teardrops, there are microcytes, hypochromic cells.
Mm-hmm. Right. So the blood film is consistent with.
With some on the basis of his I'm not sure what should I say it's consistent with. Maybe I couldn't find any NRBC. There are no basophilic stippling or
Mm-hmm. So we had a film like this in the exam, and they asked us write down 6 findings.
one is
You-
microcytosis, one is anisocytosis, poikilocytosis, teardrop, microcytosis, hypochromia, no NRBCs, no basophilic stippling,
Okay.
fully hemoglobinized cells. Mm,
D- dimorphic blood
target.
picture.
There are even no target cells in it.
Okay. Right. Did you see any whole jolly body in this picture or not?
No.
Yeah, there were
Have
couples
you-
of whole jelly bodies, yeah, and target cells as well.
It's 1 o'clock.
Okay. Right. So you can expect such question in exam as well, like write 6 points because the report is 6 marks. So they asked us write 6 points in this blood film. Okay, right. What further test you would like to do?
Further test.
Yes, this is the blood film. The patient is anemic, microcytic. The blood film is in front of you, and the patient does not know the diagnosis. He is immigrant to the UK. He has been transfused, but we need a diagnosis for this patient to bring her under our NHS services if she has any hemoglobinopathy.
I would like to ask for the test of hemolysis along with the HPLC and the parents, both parents CBCs and their HPLCs.
Okay.
But I'm not
You
sure
would,
that if this patient has recently been transfused, then HPLC would not be of much help.
okay. So this patient has been transfused in the ED because her hemoglobin was 52 and she was symptomatic, tired, short of breath on exertion as well. So she has been transfused. Okay. All right. So you would like to do HPLC. FBC is in front of you, and then if there is hemoglobinopathy, uh, would you like to confirm that on a second test as well?
Yes. Because
Hemoglobin electrophoresis.
mm,
You can make diagnosis of hemoglobinopathy if there is
few tests are positive of
mutant.
different methodology.
Yeah. Then the patient mother gave you an HPLC. that,
Mm-hmm.
that this HPLC was taken 4 years ago.
4 years ago. So there was a peak in the S region, which accounts for 70.8%, and another in the A region, which is 18.4, I guess. So
Yeah.
S is more than A. We ignore the A2 peak in the presence of sickle peak. These HPLC findings are more consistent with sickle with beta plus thalassemia. And her indices
Okay.
are also microcytic hyperchromic. So there she is more in consistent with sickle beta plus thalassemia.
Yeah. So can you explain to the audience again, how did you make a diagnosis of sickle beta plus thalassemia on the basis of HPLC, and why it is not sickle beta not?
Because if it is beta naught, so there would not be any A peak. And the other differentials is sickle trait because it also has an A peak and S peak. But if the S peak is more than A, then it is more consistent with sickle beta. If A is more than S, then it is more consistent with sickle trait. Usually in sickle trait, we have 60% adult hemoglobin and 40% sickle hemoglobin. But if this ratio is reversed, then it's compound sickle with beta. And also the RBC's indices of the patient will also help you to confirm this diagnosis. Usually sickle cell anemia is normocytic normochromic. But whenever there is microcytic hyperchromic indices, your differential will include sickle with beta, sickle with alpha, or it could be iron deficiency with sickle.
So if A naught is above 5%, then you call it as beta plus. If A naught is less than 5%, you call it as A naught. This patient has 70% sickle hemoglobin, 18% of A naught. It becomes sickle beta naught.
One possibility is if
Sickle
there
beta plus,
is
sorry.
not A2 and there is only sickle and A, then there is a possibility that sickle patient has received a transfusion.
Yeah, but this is an old um,
This is the old thing.
HPLC in this patient case. And if it is sickle beta naught, you would expect an RBC in the blood film as well. Right?
So this is yes. So this is a case of sickle beta plus thalassemia.
Sickle beta plus thalassemia. And if it is a Viva case, in Viva, they would ask you about principle of HPLC. They would ask you about uh, how would you assess a new immigrant patient in your clinic. So you would write all the details from A to Z, um, from checking the vitals to enrolling him into the hemoglobinopathy services. So there are new guidelines in the BSH regarding the thalassemia and hemoglobinopathy, and HemeBase has summarized that. in 10, 11 points what you would like to do in hemoglobinopathy patient when you are enrolling it into the services. Or I would advise you to see the annual clinic letter of a thalassemia patient or sickle cell disease patient. It has all the required information that we usually ask from them and that you need to mention in the exam. Then the
So,
other viva, mhm,
sorry, go ahead.
yes. Then the next viva question would be regarding um, indications of chelation in such patients because they are usually transfusion dependent. When would you start iron chelation for them? Then next questions would be what are the different drugs that are used for iron chelation, and then what are the side effects of these drugs? Because this patient is young, uh, she is planning pregnancy, or she came to your clinic on next visit with 6 weeks of pregnancy. What would you like to do now? Or they can ask you regarding the complication, acute complication of sickle disease or chronic complication of sickle disease as well. So sickle cell disease can be a 7-minute long question in general survival. And the new treatment for sickle cell disease, uh, the cell therapy for the sickle cell disease, which has been approved last year by NICE. You just remember the name that you know you are aware of this new therapy, and that's it.
Sorry, which one?
The cell therapy for the sickle cell disease patients.
Is
It
it
is
still
mentioned in
pending?
the it is mentioned in the heme base.
So why don't we find any sickle cells or goat cells in this case because of the transfusion?
Transfusion, and she's not sickling at the moment. That's why
So can
she
you
may have
any
she may have
focus any
she may have
homozygous?
yeah, she may have concomitant iron deficiency as well. But at the moment, she does not come with any sickle cell pain or anything else like that. And the HPLC was an old HPLC. If it was a new HPLC, it would not be like that.
Can you focus any Howell Jolly body?
This is a small one. Let me check a more prominent one. This one can be. Let me check more.
So how would we report this case in exam if we are not given the HPLC and there is only microcytic hyperchromic cells and the history is suggestive of some hemoglobinopathy, but we are not sure what it is exactly. But it seems to be iron deficient picture more.
So
So
just like the other blood films where you commented on the red cells, white cell, and platelet, and then you give you are suspected that most likely consisted with, and then you suggested further investigations uh, like
I'm asking
HP,
in this
Mhm.
case, what would be our most consistent suggestion? What would be our suggestion?
HPLC and electrophoresis.
No,
These are
no,
the two
that
tests.
no, these are the two tests. The findings are main diagnosis. What is that?
I did not get your point.
I said that there is microcytosis, hypochromia, although I couldn't find any NRBCs or basophilic stippling, although the history is consistent with some with presence of some hemoglobinopathy, but my this blood picture is not consistent with any of the. I cannot say whether it's a sickle cell trait or it's a sickle cell disease or it's hemoglobin C disease or it's just iron deficiency. So what would be my conclusion in reporting that these findings are consistent with iron deficiency or
So
hemoglobinopathy?
you would say this blood film contains microcytosis, hypochromia, multiple target cells, whole jolly bodies, uh, plus transfused red cells as well, or you can say dimorphic picture in the beginning.
Mhm.
The white cell count, the platelet counts are normal. Uh, the most likely, the blood film is most likely consisted with a red cell hemoglobinopathy or iron deficiency anemia. We mentioned teardrop cell as well. To find out the exact diagnosis, we need iron studies for the patient and um, HPLC. So if HPLC is positive, then you will go for electrophoresis and genetic test.
Thank you.
Yeah.
As this patient has recently been transfused, still we ask for HPLC or electrophoresis.
In transfused cases, it is a bit difficult to find out exact diagnosis, but you can send the blood for electrophoresis even, or wait for some time to uh, make the diagnosis. But in exam case, um, they would generally ask what are the investigations for the diagnosis of hemoglobinopathy. But you need to remember that you need to confirm the diagnosis on two tests, not on a single test. Because if I
Thank
send genetics for this patient, it will take a lot of time.
thank
Okay,
you.
right. So this was our uh, session 6. These sessions are free. I'm not going to monetize it, so I will request for donation. Thank you for those people who are donating me. And then please subscribe our Hematomorph channel. It will encourage us. And in the last, thank you very much. See you next week. Take care. Bye bye.
Thank you.
Thank you.
Okay.
Thank you.